Welcome to today's episode, brought to you by the Women in Medicine Summit, a transformational CME conference happening September 13th to 14th at the Drake Hotel in Chicago. Engage in leadership programming, learn negotiation skills, receive on-site coaching and mentoring, and see who will win this year's I Stand With Her awards. This year, we're excited to offer unique programming that includes a special session on how using improv comedy can bring fun back into medicine. We also have financial sessions tailored to help you navigate the complexities of personal and professional finances. Discover ways to advance into leadership roles, combat burnout, and either reignite your love for your current role or find joy in a new career path. Don't forget our Friday evening gala, a highlight this year you definitely won't want to miss. Register now at womeninmedicinesummit.org and be part of the movement that is shaping the future of healthcare. Join us to network, learn, and celebrate the power of women in medicine.
Welcome to the Revitalizing Doctor podcast. We interview trailblazers in medicine that embody the Revitalize Women vision to empower women to innovate and influence medicine, to value authenticity, respect, and work-life harmony. We recognize the challenges in medicine, and we're committed to providing coaching-informed strategies to help you go from surviving to thriving. I am very excited to have Dr. Anne Meneghetti on the podcast today. She is the physician executive who leads the medical information team at Epocrates. After training in internal medicine, pulmonary, and critical care specialties, she worked in healthcare policy before joining the Epocrates team in 2006. Her team creates and curates clinical decision support tools for the moments of care. And I have been a user of Epocrates for as long as I can remember. I really enjoy using the pharmacy support. That's my go-to when I'm looking for medication dosages. And that's been, maybe since I was a medical student, I'm not sure. So this is actually very exciting for me to meet the woman behind the scenes that's making this clinical tool work for me. So thank you for joining us.
Oh, thank you so much for having me.
So what I love to start with on our podcast is starting with, why did you become a doctor? And the reason I ask that question is, I think similar to me, you probably had no clue that you would end up working for Epocrates or that your career would go in this way. And I think that's a really profound message to get out to our listeners. So why did you become a doctor?
Well, it's interesting. I actually had no clue growing up that I would become a doctor. I had a rather dim view of physicians growing up. I associated them with, as a child, sitting in a cold room in a thin paper gown, waiting for them to show up and ask me embarrassing questions in front of my mother. And whatever conditions I had as a child, mono or whatever, it didn't seem like the physician was in a position to do anything about it. So I didn't have a great perspective on physicians, even though my mother was a nurse. And it really wasn't until I got to college and I was a liberal arts major. I was forced to take a biology class and I tried to get out of it. I tried to maneuver my way around it, but they made me take Biology 101. And it was amazing for me. I started, thinking about, my goodness, the lungs breathe, the digestion occurs, neurons are firing, all these things are happening in the body that I'd never thought about, never knew about. And I became amazed and fascinated by human physiology. I basically fell in love with the marvel that is the human body. And it was that drew me into medicine. So from an elective I didn't want to take to making that my life's work was a big transition that happened my freshman year of college in Texas.
Wow. I just love that story because you tried to stay away from it and then it found you and you caught, the bug for medicine. So over the course of a career in medicine, many physicians move from the bedside into other roles that increase their impact. What did that transition look like for you?
So as a physician in training, I did internal medicine, pulmonary and critical care fellowships. the things I loved about it were the intellectual diagnostic part. I loved that satisfaction of being a detective and figuring out, oh, this is SIADH, or this is a rare tumor, or this is temporal arteritis. And I can to this day remember some of those fascinating discoveries. So I like the intellectual part of it. And of course, I love the satisfaction of patients telling me, I feel better. Thank you. And that gratitude was a real important part of my satisfaction. I also found that I loved teaching it forward, taking whatever I learned, especially if it was complicated, like let's say acid-base disorders or which antibiotics are good for which condition or how to manage a ventilator. And I would turn those into these like one-pagers for my colleagues and for students. So I love that teaching element. It really happened. There was a point one day I was in the pulmonary VA clinic and I was in between patients waiting for the next patient to come in. And I started thinking, how many patients am I going to see today, this week, this month? And I took a prescription pad off the desk because this was before EHRs. I turned over that prescription pad and I started calculating how many patients am I going to care for in a year, in a decade, in a career of practice. And the number was large by one measure, but it just felt small to me. And I began to think, how can I make a bigger difference in this world than seeing patients one at a time? So I was still in my fellowship at that point, in my pulmonary fellowship. And I started thinking, what are the ways I can make a bigger difference? And the three that came to mind were, one, I could do research. Two, I could teach. And three, I could do health policy. And all three of those I tried. When it comes to bench research, I had a great role model. When I was in med school in Dallas, Texas, Brown and Goldstein won the Nobel Prize for cholesterol. And I watched them go from bedside, where they were caring for a 6-year-old girl with heart attacks, Stormy Jones, who, had familial hypercholesterolemia. And through studying her and going into the lab and understanding cholesterol, they revolutionized our understanding of the role of cholesterol in heart disease. And I saw that beautifully happening, bench to bedside and back. And so that was my role model. And I thought, well, maybe I could do something like that. And so I began to do bench research in a lab in Boston. And I found that my experience was very different. I spent a lot of lonely nights pipetting things, into test tubes and lab dishes and so forth. And I realized that the likelihood that I was going to come up with some major breakthrough that was going to, benefit humanity was slim to none. And it was a lonely existence. And so I realized that that wasn't going to be my path. It was doing research. So I thought about teaching, and I love teaching. And I was hoping that there'd be some place where I could just teach. And that's all I did 100% of the time. And what I found is that most institutions, they're looking for people who are teaching as part of their role, but they're otherwise, doing research and grants and doing a lot of other things. And there didn't seem to be a great set of opportunities for people who only wanted to teach, which is what my situation was. And then health policy, I did teach some, but I didn't seem to find a path for full-time teaching. And then health policy, I went to work at Blue Cross Blue Shield in Massachusetts. And I thought, well, here's where I can make a difference through healthcare policy, through coverage decisions, through setting the terms about what is covered and what's not covered, focusing on quality and quality measurements. I really thought I could make a big difference there. And I did that for the better part of a decade. And still, there were 2 million lives at that time that were covered by that health plan. I wanted to make a bigger difference still. So I essentially took some time off in 2005, and that was right when Hurricane Katrina hit. And I was in Boston, and I was headed to India to do some volunteering, just to take a break and do some charitable work. And I heard that there were some professors from New Orleans who were being adopted by MIT and Harvard because, New Orleans was devastated. So I thought, I'm going to be in India for 3 months. I've got a house here. there's people that need housing from, displaced from New Orleans. So why don't I just call them and see if they have anybody who needs a place to live while I'm in India? So sure enough, they hooked me up with a family of displaced professors, and I went off to India. And then I was getting ready to come back from India and start looking for a job. And I got a message from them saying, can you please stay away longer? Because our kindergartner is just getting acclimated here. And I thought, how can I displace the Katrina family who's been displaced? So I said, okay, you can stay in my house longer. And I flew to San Francisco with my backpack from India and decided to hang out with my brother and my family here. And so I ended up, while I was here, finding out the job from Epocrates. And it was in Craigslist, because this was before LinkedIn, before some of the modern ways we find jobs these days. And the job said, we're looking for somebody who's a physician who has interest in putting the content together for the Epocrates app. And I thought to myself, there are physicians out there who are smarter than I am, who are better business people than I am, and who are more tech savvy than I am. But there is no one who is more excited about this job than me. And this is my dream job. I want to work at Epocrates. It has a huge reach. It reaches more clinicians than any teaching institution could. And through reaching clinicians, I can, support patient care for countless numbers of patients. So I was super excited about the role, and I basically convinced them to hire me. And that was 2006. And I haven't turned back. I'm still at the same job for the last 16 and a half years. And now I lead the team that puts the content in the Epocrates app. So that was my journey to Epocrates. And if it wouldn't have been for Hurricane Katrina and my time volunteering in India, this opportunity wouldn't have even been known to me. So it's a very roundabout way, but it was the right way for me to get to my dream job.
I love it. And your story really resonates with what we're trying to share with our listeners at Revitalize. And I just want to highlight a couple of things that we think are really, really important for women physicians, and maybe try to get at how you had that in you. Because it was 2006. I started medical school in, it would have been right around that time. I graduated in 2011, and there wasn't a lot of language around what the experience was for women in medicine. I tell listeners quite often that my experience was that there was near gender parity when I started medical school. And many people told us that there really wasn't anything to be worried about now that there was 50-50 women in medicine, at least going into medicine, that you weren't going to really have any challenges when it came to discrimination and bias. And so then once you started to see that that's not exactly what's happening here, then it was very hard. So I want to highlight for our listeners, you said something about there may have been better clinicians or tech people, but I knew I wanted this more than anybody else. I think that's such an important message, that you channeled what you were passionate about, and you were pretty sure that was going to be enough. So how did you know that? What life experiences or mentors or people had you developed that confidence, that trust in yourself, that the passion was going to be enough?
It's a good question. Growing up in Texas and going to medical school in Texas at an earlier time point than you were in school, there was that perception of certain doors were open to women more than others. When it came to this, I relied on the fact that I'm a good learner. And throughout my experience, I've connected with teachers, and I've been a teacher, and I know what it is to learn. And I think that it was really the idea that I could learn technology. I could learn business. Working at Blue Cross Blue Shield also gave me a sense of the business side of healthcare. And it taught me the important lesson of humility, that, a lot of physicians are kind of the captain of the ship when it's in their domain. And they're the ones giving the orders. They're the ones calling the shots. In business, the title doctor comes off, and I am one of many people There's experts in finance, experts in technology, experts in, human resource management, and so many other things. So I put myself, when I was at Blue Cross Blue Shield, in that position of learning. And I understood that I can master through learning on the job certain kinds of things, like the technical side, like the business side, like the financial side. And so I was confident that even though, there were docs who were nerdier than I was about technology, there were docs who are smarter than I am, and there are certainly docs who have a better business entrepreneurial spirit than I do. I knew that I could learn those things that I didn't have as long as my passion was there. And that's what carried me through. So my own passion is what gave me the confidence, and my experience in learning things beyond my sphere of education from the past. And also the humility of knowing when I worked at Blue Cross Blue Shield that if I have the humility to learn from those around me, despite having MD after my name, that doesn't make me the captain of the ship. I am one of a team. And so I had that sort of collaborative mindset from the start.
I love that. And that's a phrase we use very often here is you don't have to go at it alone. Medical training does a disservice to people. I look at my interns and there's this culture that we have that you must do everything. You must call the consult yourself. You must schedule the patient's follow-up. You must write this note. And that's not what we should be doing at all. And I think, on one hand, yes, interns should understand how to start their own IVs and some of these other skills. But we have to very quickly, I think more quickly, start teaching them how to work more collaboratively. Because part of the reason we founded Revitalize was physician burnout. And I'm just curious, did you ever experience burnout in your career? Was that part of the reason to pivoting to Blue Cross or to your work at Epocrates? What does that term mean to you? And did it play a role for you?
So it wasn't so much burned out as wanting new challenges. Like leaving Blue Cross, I had already left practice at that point, but I had run out of the challenges that I was looking for. So I love being on that sharp curve of creating something new, learning something new, and moving. So I wasn't so much burned out as hungry for more, thirsty for some fresh challenge that I wasn't getting. So with Epocrates has moved from a private company to a public company to being acquired, and it's constantly been evolving, and the technology is evolving so much that it has always been refreshing to find the next new thing. And throughout my time at Epocrates, these 16 and a half years, there have been opportunities where I could say, hey, you know what? People love clinical practice guidelines, but it's really hard to dig through those 80-page PDFs to find something at the point of care. How can we turn that into a 90-second algorithm that clinicians can just grok within seconds rather than digging through? And taking those problems and turning them into solutions, that opportunity keeps coming up through the Epocrates app. So I have avoided feeling burned out because there's always new problems to solve and opportunities to use technology to solve them. So I haven't been affected by burnout per se because the role itself has sort of built in evolution and challenges and fresh problems to solve.
Stay tuned. We'll be right back. Are you a physician mom with school-aged children feeling utterly exhausted? My friend Dr. Sheeta Shaffi invites you to take a little time this summer to join her in a small, intimate group for meaningful conversations. Dr. Shaffi is an emergency physician, coach, and mom to 8-year-old twins. She understands firsthand what you're going through. This isn't a pizza party or a yoga class. You'll meet for 2 one-hour sessions twice a month starting in July to help you move out of exhaustion, let go of mom guilt, and live a life you're not only proud of, but can truly enjoy. Connect with her on LinkedIn or Instagram at Sheeta Shaffi to learn more. Sheeta is spelled Shideh, and Shaffi is spelled Shafie. You can also check the show notes for a link so you can connect with her there as well. That's amazing. And that's probably a really interesting question for our listeners to reflect on. Are you burned out or are you bored? Where is the edge? Where's the edge where you're working? Where can you create more challenges in a good way? Not challenges and like hardships, but I mean, most of us are intensely curious. That's why we went to medical school. And are you able to satiate that in your day to day? I want to turn a little bit to the tech side of Epocrates. And in some ways, I felt I've been practicing in the worst of times in medicine when it comes to technology and electronic medical records, which I know Epocrates obviously isn't an EMR, but what I want to just pick your brain on, because you're in the tech world, these EMRs are really billing generating systems, and they're not what most doctors and what most patients want them to be, something that has clear communication of the patient's medical care and supports the clinical decisions that physicians are trying to make. I am maybe the most optimistic I've ever been, though, as I'm starting to dabble, learn more about AI. What role do you think AI is going to have? What's happening with AI that you can talk about it at Epocrates? How are you optimistic about the future of medicine and technology?
Yeah, great question. And, Epocrates is part of Athenahealth, which does have an electronic health record as part of its portfolio. So I have a little bit of insight into how good EHRs can support things, the workflow. But I divide my answer into two components. One is in communications and the other is decision support. Those are two areas that I think that AI or technology in general can be supportive. When it comes to communications, there's obviously the documentation. Can AI do what a scribe could do in terms of just documenting the physical conversation, the history and exam, et cetera? When it comes to patient-facing visit recaps through the patient portal, could AI take a clinician's records and turn it into something that could be consumed by the patient as a visit summary, for example? Prior authorizations, the bane of many clinicians' existence. In some cases, you have to get a prior authorization for a generic drug in some cases, much less for certain procedures and other things. So prior authorizations are very ripe for an AI solution, taking items from the medical record and turning them into the documentation needed to match the criteria for a health plan to give approval. The things like camp physical forms or workers' comp forms, et cetera. I think there are a lot of things that clinicians do that are not at the top of their license, as we say, in terms of intellectual activities that could be done by an AI with somebody glancing at it to make sure it's okay. Essentially, anytime there's something that feels repetitive, that we despise spending time on, that is inspiration for, could this be automated? Could it be streamlined? Or in some cases, could it be done by another human other than me? So I think it's those pain points that in communications and documentation that should lead us to think about, like, what else could AI do for us or technology in general? When it comes to decision support, I think that's another story. Most clinicians I know do not want their decisions being made by, a chat bot or crowdsourced from, the web. They want decision support that is evidence-based, well-researched, and, from expert opinion. That said, I do think there are ways that technology can help. For example, let's say I've got a patient that has failed first-line therapy, second-line therapy, third-line therapy, and I want to know, is there a clinical trial for this particular condition, for this stage of disease, for a patient of this age, in this geography, that is open and recruiting patients? That information is hard to find today. clinicaltrials.gov is out there, but doesn't always have the most up-to-date information. And there are questions like that it would be great to have some technology go out and answer a question like that to support a decision. In the real-time order flow, let's say that a clinician is ordering something and a system that could be smart enough to say, well, usually when you order this, you also order that. Do you want that in this case? Technology could support clinicians in their thought flow. But the idea of sort of things like ChatGPT or other technology that sort of goes out to the web as its source, what comes back is only as good as the source material that went into it. And I think clinicians want expert, evidence-based advice, not sort of crowdsourced internet advice when it comes to their decision-making.
Wow. There's so much there and it's so exciting. I was sitting in what we call the doc box at my shop in the emergency department, and a clerk walked back one of those worker comp forms that you're mentioning. I was like, oh God, please don't let it be me. Don't let it be me. And then it was my colleague that got the form. And I just saw him like his shoulders go, oh. Because you're right. It's so like, oh my gosh, I just documented my chart that literally says everything on this form. It says what the diagnosis is. It says what happened to them and what I think the implications are. Like, why would we be spending our time on that? And we're under so much time pressure in the emergency department. I mean, all of our colleagues are, but, I just think about how frustrating it is when we're like dealing with somebody that's actively dying or resuscitation and to have these distractions. So I'm really hopeful. My question for you, that knowing that you're in the seats of many of these conversations, what is taking so long? I mean, now that I can use ChatGPT, I'm like, please tell me that big companies involved in the medical space have been working on this for the last 10 years and we're on the precipice. I mean, am I going to have to wait another 10 years for some of these things to actually come in? Because quite frankly, I don't know if I'll be at the bedside.
Definitely, companies like Athenahealth are definitely looking at how to ease it. Things like prior authorization, things like that, forms, whether it's through AI or whether it's through other kinds of support. The idea that a clinician should be working at the top of their license, period. I think for physicians today, if we see technology being used in other parts of our lives, it just makes good sense that it could be used in our careers as well. And I also think about it in terms of like technology in training. I know you do a lot of simulations and training. When I think about, let's say, virtual reality for use in teaching procedures, if it's used for a pilot, could it be used also? Could virtual reality be useful for surgical procedure training? And I'm curious to know, for you, have you thought about using VR in your simulation training?
Yeah, that's a great question. So I've had limited exposure to some of the VR technology. We don't personally use it at my site in Temecula, although I teach in the master's program at the Naval Postgraduate School in their simulation certificate master's program. And certainly the Navy is much farther down the VR in AR, augmented reality pipelines. It's been a while since I've done some of the procedural training with the VR, but I think you understand with your background in critical care and pulmonology that when you go to do a procedure like a thoracentesis, the haptic feedback that you get by picking up the instrument and going through the skin and then going through the muscle, popping through the pleura, that to me is where there's still some limitations, that it just doesn't feel that realistic. So for me as an educator, what I think the application is right now is early on in the learning process when learners are more about learning the steps of what instruments do I need and what order do I do the steps. I think VR makes more sense, but I think we need, in the simulation world, the word is fidelity. We need more fidelity, realism after that. But if there's anybody out there listening that thinks they've got some VR that bridges that gap that I'm talking about, I'd love to hear about it. Shoot us a comment, tweet at us, email us, because I'd like to keep this conversation going.
Cool. Another thing I'd like to see is a better integration of Epocrates within EMRs. Right now, Epocrates is a separate app on web or mobile, and Athena Clinicals is the only EHR that has Epocrates built in to a limited degree. It has some drug information excerpts, for example. But it would be fantastic to have the drug interaction technology of Epocrates more accessible. For example, a lot of EHRs, they all have a drug interaction module that'll give you a sort of a red light or a green light about prescribing this drug and that drug at the same time. But like with Epocrates, the drug interaction information goes a lot deeper. It'll say, for example, if you're going to give these two drugs together, half the dose of this one so that it won't interact as severely, and watch the potassium levels. It'll give like practical, actionable guidance on how to manage a drug interaction or avoid complications from a drug interaction. That's the kind of information you don't typically get from an EHR today that just might say, contraindicated, red light, green light. Or just wanting to know what dose is appropriate for this particular circumstance. Having to pull Epocrates out of your pocket, wouldn't it be great if it were already in the EHR where you could sort of see that information served up in the flow of work rather than having to go to two separate places? I would like to see more integration of sources that we have available to us today within the EHR workflow rather than having to go outside of it to get that kind of quick information.
100%. I mean, I think from a workflow and, dare I say, a patient safety standpoint, it makes sense. I mean, I think about, sometimes, but quite frequently, I have to, with pediatric dosages, use something like Epocrates, calculate it on my own phone. And then you're trusting that I transcribe that back into the EHR correctly, which I think I do a good job. And I know that the pharmacists are checking too. But why do we tolerate that step? Why is that okay? And I'm sorry, I'm going to get on my high horse a little bit here. Also, these systems are pushing the costs of many things, whether you use Epocrates or use a different thing like Pepid, on the physicians. The physicians end up having to pay for these things out of pocket. And so then, you get a bill for something, one of the things you are subscribing to, and you're like, well, maybe I'm not going to renew because it's X number of dollars a year. So I would really challenge the healthcare systems, and if we have any administrators listening, to think about how can we embed more of this, that it's not counting on the physician or the nurse, the pharmacist, to pull out their personal device. I think I should have access to it if I want to. But why is that always the answer, that the individual physician has to pay out of pocket or be the glue that's holding this incredibly, well, many of us feel fragile system together?
Yes. And even if you're perfectly accurate in your sort of transcription from one device to the next, there's also just the time factor. Let's say that patient's on 12 drugs and, you could just accept whatever your EHR says, but if you want to get the Epocrates ones, you've got to tap into Epocrates and select each of those 12 drugs to see all the interactions there. And that's time consuming.
So I want to take a step back. And you mentioned Athenahealth has some of the EMR side, or has the
Correct.
EMR side. And so I practice in San Diego, and I've worked in a number of hospitals. And I would say most of our EMRs break down right now into either Cerner, which is often called FirstNet, and Epic. So for our listeners out there, what is Athena? Is it involved in either one of those, or it's something else?
So Athena's EHR is Athena Clinicals. That's the name of that EHR. And it is very, very commonly used in the outpatient space, more so than the inpatient space. And it is, what I think is unique about it is always been cloud. It's been cloud-based. And therefore, there's not like, here's your version of it inside this hospital that doesn't interact with some other version that's in some outpatient setting. There's just one instance of it. It's all in the cloud so that all the information is accessible to everybody at all times. And it is made with the physician in mind. And they're constantly taking advice from practicing clinicians on how to make it better and what different specialists have in their workflows that needs to be adapted for their particular use. And so it has decent ratings in terms of usability, and they're constantly making breakthroughs in terms of how to make it adaptive to the way clinicians work so that they can spend more time focusing on the patient and less time staring at a screen or managing their inbox late at night.
So part of the reason I asked this, and I'm kind of using this as an opportunity to tell you all my pain points. And as I'm learning more about AI, there was just something that came out a couple weeks ago that you can take a picture of your pantry and the website, whatever AI can figure out like, hey, these are the recipes that we suggest based off what's in your pantry. So as I'm sitting here talking with you, and this is why I love hosting this podcast because I never know what's going to come up. Part of what is hard about being a doctor and a patient in our current system is it is there's so many different entities. It's very fractured. There's not like, I'll take example, my hospital. My hospital is a private hospital that doesn't have clinics associated with it. And many of our patients actually belong to another healthcare system and access our hospital very frequently. So something that will happen all the time. We're very busy. And while maybe in general, the expectation is that when the patient checks in, the nurse would get the medications and upload that into the system. That involves him talking to the patient. Oftentimes they don't know what their medications are, or they bring in like the huge bag. And it's very tedious trying to get it uploaded in. So many times when I go to prescribe something, if I'm discharging them, or let's say I was even giving them a medication while they're in the ER, I don't have their medications uploaded into the system. So I'm just thinking, like, aren't we at the point where somebody could take a picture of all of those medications and it could get transcribed into a computer system? And why aren't we doing that?
That is a brilliant idea. Patients bring the bottles and the containers. That is likely doable. What often happens is that, like, let's say an emergency medical technician comes and finds a patient with a fistful of pills in a suicide scenario.
Yes.
They're seeing these, let's say it's a blue pill with a W on it or whatever. They can use Epocrates to our pill ID, which is free, to say, okay, it's a round pill with a W imprint on it. And then get a list of what those pills, what it could be. And then once they've identified the actual pill, then once they see a match, then they can obviously give the right treatment. So we've heard so much from EMTs who have said, thank you, Epocrates, for this pill ID because it's saved a life. They've also asked us, couldn't I just take a picture of the pill or the capsule or the tablet or whatever, and you tell me what it is? That would save me having entering in, some of the details of the pill. And we've actually started exploring that. We don't have an answer yet, but the technology is likely going to get there one day where you could just literally take a picture of the pill. Some of them are just white, small white circles that don't have any imprints on them. That's hard. But a lot of pills do have some characteristic imprints and things like that. So that technology should be getting better and better. I remember frequently encouraging patients to bring in that brown bag filled with all of their bottles. And if they bring in the bottle, then that makes it a lot easier. But it's still tedious for somebody to have to enter that in, even if it's a medical assistant or someone else. It's tedious to enter that stuff in. And a lot of mistakes get made in those transfer points. So leaving the ER, going home, or leaving the hospital, coming home, because people aren't always aware of all the things that a person is on. I could remember with my own father, who's now 91, we were going on a trip somewhere and I looked at some pills he had. I said, what is this one? I ended up looking up what it was, and it was an antiarrhythmic he had been put on years ago as part of a heart surgery, but it was only meant to be given for a very short time. And his primary doc didn't know what it was, but thought it must be important. So he kept refilling it for years and years and years, but he shouldn't have been on it. So it's at these juncture points of discharge that oftentimes mistakes get made and sometimes perpetuated, or people will be on, two of something that are doing the same thing and not know it. So having that universal record, that interoperability is so important. And it seems like it's doable with, certainly EHRs all have a responsibility to be interoperable and share information while protecting people's privacy, of course. But that's something that should be solvable.
Wow. Well, I am more optimistic than when I started this conversation today. You've opened my eyes to some of the great things that are on the horizon. And, I think given the staffing shortages that we're facing, it's honestly, I don't think it's very realistic to expect that there's going to be workers, unfortunately, that are going to fill some of these jobs. I really do think it's going to require technology to step in to do some of this more things that are repetitive, that we could really lean on technology for. A lot of our listeners are probably feeling super excited right now and maybe thinking that they would like to move into this space. Because I think that we're at the same, and it feels to me, even though it was very small, like when the internet was coming out, that there's going to be a huge need for physicians that understand these pain points and that could come up with solutions and work with companies like Epocrates on what's going to happen with the integration of AI into clinical medicine. What would be your advice for a listener that's excited right now? And I mean, obviously, probably don't go to Craigslist, but where should they go? Who should they talk to? How do they break into this space?
Yeah, a great question. My sense is that technology companies need clinical advice in order to make their products tailored for the clinical moment of care. So if there's a company that you're interested in or that's doing work that you like, if they don't have any postings for jobs for clinicians, one thing to do is just to simply write to them, to email them through LinkedIn or directly to the highest placed person you can find in that company and offer your services. Just say, do you have an advisory board? Do you have a need for people to weigh in a focus group? Or could I write something for you? Describe your assets, your interests, your passion, and see if you could be of use to them, even it might be in the beginning in a volunteering way or as a contractor, but propose the kind of ways you could be useful to them based on your passion and interest. There's also, for example, a New England Journal of Medicine Career Center I think it's May 18th. They're having a free live stream on navigating career opportunities, including like exploring secondary sources of income or non-clinical paths for careers. And for those who are interested in finding their purpose and their satisfaction in other ways than direct patient care. And so I'm planning on attending that. Also, just out of curiosity to hear about some of the kinds of opportunities that are out there in medicine for clinicians who are looking to expand.
That's awesome. And I also, obviously you've been at Epocrates now for 16 years, and that is striking to me because usually what I hear when I listen to podcasts like Pivot and about the tech world is that most tech jobs are kind of short-lived, and there's a lot of turnover in that space. So I'm curious if you can just share what free services that physicians could use from Epocrates, if maybe they haven't been using it or they used it and they're onto something else and maybe want to come back and give it a try.
Sure. So Epocrates is a clinical guidance tool that's used by over 1 million clinicians, and it's been the top mobile medical app for a couple of reasons. One, clinicians say it saves them time. When we survey clinicians and ask them how much time they save, well, half of them report 20 minutes a day by using Epocrates. And in 20 minutes, you could see a whole nother person, a whole nother patient. So that's significant. And then in terms of practicing more safely, almost half of them say that they avoid one adverse drug event a week by using Epocrates. So it helps them practice more safely. And in many cases, it's not that it's teaching them something new. It's that confirmation of like, yes, that's what I thought it was. Oftentimes they're looking up drug information that we're famous for, or using our drug interactions, which are practical and actionable. I think the other things are they can get speed to answer for things like clinical practice guidelines. So like keeping up with, let's say, something like colon cancer screening or cholesterol management or diabetes or diagnosing mpox, for example. If you want a quick 90-second, what do I need to know for this patient in front of me, a patient with these characteristics? What do I need to know? It's based on these expert society guidelines. You can get it very quickly. Sure, you could go read that 80-page PDF and say, does that apply to my patient? Does that apply to my patient? Does that apply to my patient? Or we've done that work for you by turning it into an algorithmic, quick experience where by the type of patients, everything that you need to know from these expert guidelines is synthesized. And even when there's contrast, for example, this society says do this, this other society says do that, you're the one choosing. It's all laid out for you by the type of patient. So I think that the clinical practice guidelines and decision tool section is one that a lot of clinicians don't know about. And it's part of the free app. So people can access those topics like insulin. How do you find an insulin that's of a certain type that's more cost effective than another one? These kind of quick decision tools can support them in that within 90 seconds or less without having to kind of go through multiple sources to integrate that information. And
Wow.
pill ID is another one. What is that mystery pill? It can really help when the patient doesn't have the bottle. It's a great way to get a quick answer.
I love that. Well, I'm actually having an EM shift this afternoon, so I will check out some of the more functions that I probably just have. You kind of get, sometimes with apps and things, you get kind of used to doing one thing with them. So I'm excited to explore some of the other functions within Epocrates. Is there anything I didn't ask or anything you want to share with our listeners?
I wanted to mention with technology, there's a new concept called digital therapeutics, where there are patient-facing apps that are FDA approved and they're prescribable. So a clinician would prescribe them. Some health plans are even covering them, just like as if it were a drug, that have been shown to be valuable in things like irritable bowel syndrome, insomnia, some mental health conditions. And that's going to be a really interesting area to watch. Could an app serve as an adjunct to drugs or instead of drugs in certain cases? And to see that the FDA is actually getting involved at this level to say, this one has been proven safe and effective for its purpose. And to get that imprimatur and then have them be prescribed and covered by health plans, I think is an exciting advancement. And I'm looking forward to seeing more of those. There's a lot of different consumer health apps out there, but to see this level of rigor around the evidence behind them is super exciting to me.
That is awesome. And I've been thinking about that. I didn't have the language for it, but I love that because I've been thinking, patients sometimes are in the ER. I discharged a couple of people for various reasons that were there between 4 and 6 hours yesterday. And, sometimes people are too sick to look at an app, but sometimes they're not. They are very much with it and they're highly motivated at that moment to learn more about what's making them so sick. And they have so much downtime. Why don't we use some of that? I mean, obviously not force them, but if they're sitting there or their family members sitting there saying like, I really want to know more about this, I feel like we're missing so many opportunities.
Yeah.
Well, this has been a delightful conversation. How could our listeners connect with you or Epocrates?
So the Epocrates app is for both mobile and web and for Android and iOS, Apple products. And there's feedback opportunities throughout it. And so they could email that anytime and it'll get to me if it has my name on it. And also through epocrates.com, the website.
Awesome. And you're also on LinkedIn. So
yes, I am on LinkedIn.
Encourage our listeners to check out your profile. And I just want to thank you for your leadership. And it's wonderful to see the person behind. We kind of sometimes you hear about these titles, and it's wonderful to see that you're warm, caring, kind person that understands our pain points.
Oh, well, thank you so much for having me. I really appreciate it. And thank you for shining a spotlight on these issues that are really affecting all clinicians. I really appreciate it.
Well, thank you. And I think we just scratched the surface. So hopefully we can have you back to get more into it.
Wonderful. Thank you.
Wow. That was such an amazing interview. I just found it so inspiring and really embodies what we're trying to do here at Revitalize, which is connect women physicians with their passion and creativity to transform medicine. As a special thanks, Dr. Ann Meneghetti and Epocrates have arranged an exclusive discount for all of you. You can go to epocrates.com and log into your account. If you don't have one, that's fine. You can make one. And you're going to have a discount code that's good from April 15th until May 31st. So the code is REVDOC20 because we're revitalized. So that's REV, R-E-V, DOC 20, and that will give you a 20% off code. Wow, that is so cool. I'm very excited that we have that offer available to all of you, and I look forward to bringing you more offers like this in the future. Thanks for listening and thrive on. Thanks for listening to The Revitalizing Doctor, a project of Revitalize Women Physician Circle. Our mission is to connect women physicians and allies through innovative, value-based coaching methods that align trust, support, accountability, and skill development to ignite the courage and clarity necessary to take bold actions, create change, and thrive. If you're interested in working with us, check out our website at peoplealwayshcc.com/revitalize or email us at revitalizemm.info@gmail.com. This podcast represents the views of our host and guest. It does not reflect the views of any institution we work for or with.
Hi, it's Dr. Risa E. Lewis, dropping in to tell you about a book that Dr. Adara Landry and I wrote. It's called Microskills, Small Actions, Big Impact. It's a business self-help book coming in 2024 by HarperCollins. Pre-order now. Microskills, Small Actions, Big Impact, wherever you buy your books.